Move to this question. 50-year-old male presenting 3 weeks after combined phaco trap with MMC, mitomycin C. He presented with milky appearance of a thin-walled bleb and 2+ cells in the anterior chamber. This is endophthalmitis. Slit lamp examination shows cells in the anterior vitreous, again vitritis, endophthalmitis, with clear fundus details. The AC tab most likely shows which of the following organisms: strep, Neisseria, coagulase negative staph, Enterococcus, coagulase positive staph. So we are thinking of endophthalmitis. This might be related to the phaco, but what he mentioned here is milky appearance of a thin-walled bleb. So this is a case of blebitis, which is endophthalmitis in the end of the day, but we have few organisms involved in this. So endophthalmitis after the cataract surgery is most likely caused by coagulase negative staph, which is staph epidermidis. But is it the same in blebitis? This is a question. So for these options, just to let you know, coagulase positive staph is Staph aureus, and this can cause postoperative endophthalmitis as well, but not as common as staph epidermidis, which is the coagulase negative. The answer here is coagulase negative staph. It's exactly the same like after cataract surgery. And here we need to differentiate between blebitis of early onset following the cataract or following the trap surgery and late onset blebitis. Bleb-associated endophthalmitis can occur at any time following successful filtration surgery. The most common causative organism in early onset bleb infections, which is within 4 weeks, are coagulase negative staph, the staph epidermidis group, and the patient presented 3 weeks. Okay, so this is a good question. While strep species are the most common cause of late onset blebitis. Late onset blebitis is usually related to conjunctival buttonhole. So this is very important now. If you have a bleb here and this bleb has become thinned, or there was trauma and there was a small buttonhole, it would allow the organism into the bleb, and because it's a filtering surgery, it goes inside the eye and causes inflammation. There is no evidence that blebitis and endophthalmitis are more frequent in combined cataract glaucoma surgery than in single glaucoma procedures. So this question could have been either he had combined glaucoma cataract surgery or just had trabeculectomy or glaucoma filtering surgery. Typically, blebitis is caused by external fistula, which is a buttonhole. The filtering bleb has become thinned, and then the epithelium has grown and formed an external fistula connecting the outside environment to the subconjunctival and the inside of the eye. This happens usually or particularly after MMC trabeculectomy, which has several consequences that we will discuss in the glaucoma chapter. Even quiet buttonholes should therefore be closed. So many patients might have buttonholes that's quiet, causing no inflammation, no irritation, no foreign body sensation, but it should be closed before blebitis or endophthalmitis happen. Compression sutures can help to seal the buttonhole. So if there is a small buttonhole, you can take an 8-shaped suture, compression suture. Or if it's large, like the one to the left, you can do like a purse string suture, just around the hole and close it. But if the buttonhole is in a very thin bleb and avascular bleb, this can't be sutured. Otherwise, the entry site of the needle will cause more holes. So in this case, we need free conjunctival graft, we need amniotic membrane graft, and preferably below this graft we can interpose the Tennant's capsule. So for better reepithelialization of this buttonhole, we would close Tennant's capsule first beneath the defect, and then we can place the graft, either amniotic membrane or the free conjunctival graft from the same eye, or preferably from the other eye. And this carries several risks. So if the other eye is to have filtering surgery, we are disturbing the conjunctiva. Taking a free conjunctival graft, autograft, from the inferior conjunctiva is slightly more technically difficult than superior conjunctival free autograft. And Tennant's capsule, this is very important to study the pathological changes of Tennant's capsule in patients with glaucoma. So this has to be considered as well. The glue, conjunctival glue or the tissue glue, is not effective. So don't try closing it with a conjunctival glue, applying PCL or something like that. This is not a permanent solution. So you need a graft, free conjunctival autograft or amniotic membrane graft. Stages of blebitis. This happens in 3 stages. First one is blebitis only. The organism has reached the bleb, subconjunctival space, but didn't reach the anterior chamber. So there is no cells in the anterior chamber, no cells in the vitreous. It's just milky fluid within the bleb, injection, pain, foreign body sensation, and aquasitis when the inflammation extends to the anterior chamber. And in this stage, especially in phakic eyes, there are no cells in the vitreous. And vitritis, stage 3, so there is blebitis, aquasitis, and there are cells in the anterior vitreous, subdivided into 2 subgroups, visible fundus details and invisible fundus details.